Hello, everybody. Thanks for joining us today. My name is Blake Shoemaker with Genoa Healthcare, and I'm here with you today to introduce Erzofri, a new long-acting injectable option designed to support more stable, sustained therapeutic coverage for appropriate patients. We've had a lot of questions from the field, both from our pharmacy locations and from our clinic partners to learn more about this new kid on the block as far as LAIs are concerned, and I'm here to help kind of guide that process. So our goal today is to provide a clear overview of what Erzofri is, where it fits in our therapy plans, and how it may help address some of the challenges that we routinely see in clinical practice. Now, as many of us know, medication adherence continues to be a significant barrier to achieving consistent outcomes in our patients, especially when we're talking about schizophrenia and bipolar disorder. Long-acting formulations can reduce daily pill burden. It minimizes fluctuations in plasma levels, and it can potentially improve both adherence and symptom stability in the patient journey. Erzofri introduces a novel option in our LAI landscape with its pharmacologic profile and administration schedule, and it may offer meaningful flexibility for both providers and patients. So let's jump in. A little bit about me first off. My name is Blake Shoemaker. I'm our Senior Manager of Pharmacy Product with Genoa Healthcare. What that means is basically I have my hands on anything at Genoa Healthcare related to long-acting injectables. So it has to do with the training of our pharmacists to not just dispense, but also administer these medications when necessary. It has to do with our policy and procedure at Genoa that governs what we can and can't do as pharmacists, and also our internal and external opportunities for growth in the long-acting injectable space. So just think of me as your long-acting injectable expert for the day. Looking at our agenda for today we're going to cover the topics of indication and usage, clinical efficacy, safety profile in special populations, dosing and administration, including how to manage missed doses, transitioning to Erzofri, a comparison of Erzofri to Invega Sustenna, since both of these are paliperidone-containing drugs. That's the number one question we get. SureScript guidance to ensure appropriate drug selection, and then patient support programs that you can share with your patients to help bridge cost concerns. So our discussion today is going to be centered around improving continuity of care, reducing relapse risk, and supporting patients who struggle with an oral regimen adherence. Erzofri is designed to contribute to these goals, and we look forward to exploring how it can integrate into each of your clinical practices. So indication and usage. So Erzofri is an intramuscular atypical antipsychotic designed as a long-acting injectable option for adults that require sustained system management. Erzofri is approved for the treatment of schizophrenia in adults, which offers an alternative for treatments who benefit from long-acting antipsychotic therapy. It's also indicated for adults with schizoaffective disorder as well, both as a monotherapy or as an adjunct to using oral mood stabilizers or antidepressants, which gives clinicians flexibility depending on your patient's presentation, because as we know, one size certainly doesn't fit all with all of these patients. Before initiating treatment with Erzofri, patients do have to first establish a tolerability to either oral paliperidone or oral risperidone. For the obvious reason, we want to make sure that patients don't have any adverse effects or adverse events to taking these medications before we give them a shot that's going to last them close to a month. So that step does ensure safety and reduces the risk of adverse reactions once the long-acting injectable is administered. Confirming that oral tolerability is especially important when transitioning to an LAI, since the long duration of action limits your ability to quickly adjust their therapy if intolerance starts to emerge. So that's why it's very important that we do the oral trial first. These indications position Erzofri as an option for stabilizing patients who might struggle with adherence to their oral antipsychotics. So Erzofri demonstrated efficacy early in treatment. 4 double-blind, randomized, and placebo-controlled studies, including one that lasted 9 weeks and one that was 13 weeks in the trial length, evaluated acutely relapsed adult inpatients. And across these studies, Erzofri showed superiority to placebo in improving PANSS scores, confirming its effectiveness in reducing those acute symptoms that we're always looking for. Efficacy extends beyond acute stabilization. In a longer-term double-blind placebo-controlled maintenance study, it actually demonstrated that Erzofri significantly delayed the time to relapse when compared to placebo as well. This data supports Erzofri as a strong option for ongoing system control and for relapse prevention. Erzofri offers measurable advantages over selected oral agents in real-world populations. In a long-term randomized study involving subjects with a history of incarceration, for example, Erzofri significantly delayed the time to first treatment failure compared to selected oral antipsychotics. The median time to that first treatment failure was 416 days with Erzofri, compared to 226 days with oral antipsychotics, which was a clinically meaningful difference in those results. So Erzofri delivers the same established efficacy that you would expect from once-monthly paliperidone palmitate formations, supporting system control in both schizophrenia and schizoaffective disorder. In a longer-term maintenance study that went a little bit longer, Erzofri significantly delayed the time to relapse versus placebo, which reinforced its role in ongoing disease stability. These data reinforce that Erzofri maintains the well-established efficacy profile of monthly paliperidone palmitate, while offering meaningful protection against relapse across these clinical settings. So as you can see in these charts, you do have that large gap between the paliperidone and placebo that reflects that data. So looking at the safety profile, this slide highlights the safety profile for Erzofri. Erzofri does carry a black box warning for increased mortality in elderly patients with dementia-related psychosis. I do want to point out that that class risk applies to all antipsychotics and reinforces the fact that Erzofri is not approved for treating dementia-related psychosis. Erzofri is contraindicated in patients with known hypersensitivity to paliperidone, as well as risperidone or any excipients within the formation. Hypersensitivity reactions can also include anaphylaxis, angioedema, or other severe reactions, which again reinforces that need for the oral trial to make sure we rule some of these out prior to doing the LAI administration. There are key warnings and precautions that are listed there as well. Of note, the most common adverse reactions you're going to see with Erzofri are injection site reactions, in addition to some sedation, somnolence, dizziness, some akathisia, as well as EPS. So please take note of these special populations and how these factors contribute to how Erzofri should be managed in these special groups. First up, you see pregnancy. So in pregnancy, neonates that are exposed to antipsychotic drugs during the third trimester of pregnancy are at risk for EPS and or withdrawal symptoms following delivery. So you do need to be aware of that. Overall, the studies of pregnant women exposed to paliperidone have not really established a drug-associated risk for major birth defects, miscarriage, or adverse maternal or fetal outcomes. So inconclusive on that. As far as lactation, infants exposed through breast milk should be monitored for excess sedation, failure to thrive, some jitteriness, as well as EPS as well. When we talk about fertility, it can result in an increase in sperm prolactin levels, which may lead to reversible reduction in fertility in males of reproductive potential. So that's something that you want to think about in your people who are in the age range of childbearing. Renal impairment, not recommended in patients, Erzofri is not recommended in patients with moderate or severe renal impairment. So we're talking about creatinine clearance of less than 50 mils per minute, how you would not want to consider patients for this therapy. Parkinson's disease or Lewy body dementia, those patients can experience some increased sensitivity to this particular drug, can include some signs like confusion, obtundation, postural instability, frequent falls, EPS, and some clinical features that would be consistent with what you would see in neuroleptic malignant syndrome. So those are some things to look out for there. Dosing and administration. So Erzofri uses a single dose initiation approach, which is going to be your largest difference that you see between your paliperidone injection product. So it's the biggest difference between Erzofri and your Invega suite of products, in that Erzofri has that single dose initiation. So it simplifies the transition compared to the two-dose initiation that you would see with other paliperidone palmitate LAIs. The single initiation dose is followed by an ongoing monthly maintenance injection. For schizophrenia, that you're going to see monthly doses of 39 milligrams to 234 milligrams, which are administered 4 weeks after that first injection on the loading dose. The recommended monthly dose for schizophrenia is 117 milligrams. For schizoaffective disorder, monthly doses of 78 milligrams to 234 milligrams can be administered 4 weeks after that first injection. And that 351 milligram initiation dose that I'm talking about, we're going to be discussing that in detail a little bit more in the presentation, a little bit further down the line. So Erzofri is designed for consistent once monthly administration. So maintaining the dosing schedule helps preserve therapeutic plasma levels and reduces the risk of symptom return. For patients who are only slightly overdue, the usual monthly maintenance dose can generally be administered as soon as possible without any kind of ill effect. And after you do that administration, you would resume your regular monthly schedule using the date of the late administration as your starting point. So you would continue with that monthly dose a month out from the date that the patient does come in for the follow-up dose. If the interval since the last injection becomes long enough that therapeutic levels may have declined, supplemental dosing or a modified reinitiation schedule may actually be needed in a case like that. This helps to reestablish adequate plasma concentrations before returning to monthly maintenance dosing. For patients showing early signs of symptom recurrence, a timely readministration is really critical. Providers may consider bridging in a case like that with oral paliperidone or risperidone if it's clinically indicated and allowed by the labeling. You always want to assess for relapse risk, hospitalization history, and the level of support before deciding on your next steps. And you do want to encourage your patients to schedule appointments in advance and use those reminder tools that you have available. If it's a pharmacy that's doing the administration, of course, the pharmacy needs to be doing those reminder calls, using calendar tools, appointment reminders, follow-up calls, things like that. In a medical practice, of course, calling a patient leading up to their appointment, making sure that they're aware, making sure there are no challenges related to transportation or anything similar to that. Ensure that your clinic workflows allow rapid scheduling for late or missed visits. How many times have we had a patient that missed their appointment, and before you could even call them the next day, they're running in the door saying that they forgot or they misplaced their card. You do need to have tools in place to make sure that if the patient does show up late or soon after, that you've got a mechanism in place to make sure those patients still get their dose. Consider standing orders or nurse-administered protocols to prevent delays and things like that, especially in the medical practice setting. The management approach should be based on how long it's been since the last injection. Short delays often require only a standard maintenance dose, but your take home on this is that longer delays may have to require a modified regimen to safely restore those therapeutic levels, either through doing an oral bridge or kind of looking at it on a patient-by-patient basis. So as we reviewed earlier, before transitioning to Erzofri, ensure the patient has demonstrated tolerability to either oral paliperidone or oral risperidone. What this is going to do is it's going to help reduce the risk of unexpected adverse reactions once the long-acting formulation is administered. So patients who are stable on oral paliperidone can typically transition directly to the monthly Erzofri initiation dose. Because paliperidone is the active metabolite of risperidone, plasma levels achieved with the oral form help ensure a smoother pharmacologic continuity when converting to an LAI. No oral overlap is usually required once the first Erzofri administration is given, assuming that the tolerability is confirmed. Patients who are taking an oral risperidone can also be transitioned to Erzofri after they've confirmed tolerability. Risperidone converts to paliperidone in the body, so a switch to Erzofri maintains that continuity of the mechanism and the receptor profile. Now, as with paliperidone ER, additional oral supplementation typically not necessary after initiation of the injection. Of course, you would want to assess clinical stability and look for signs of breakthrough symptoms during the first month after switching to make sure that that injection dose is going to be appropriate. You'd also want to monitor for class-related effects such as extrapyramidal symptoms, metabolic changes, orthostatic hypotension, or prolactin-mediated effects. You also want to coordinate your injection timing so there's no significant gap when moving from the very last oral dose to the first injection so that you don't have any chance for a washout of the oral medication. The transition from oral paliperidone or oral risperidone to Erzofri is generally really straightforward. After you've confirmed the tolerability, administer the single initiation dose, and then move to a monthly maintenance. This pathway minimizes complexity while supporting consistent therapeutic coverage. And as you can see in the table right there, you look at your oral paliperidone dose or your oral risperidone dose on the daily, and then you look at your equivalent dose. It's very, very easy to do this. So now we're going to look at a comparison of the benefits of Erzofri over Invega Sustenna. So this slide is going to outline those key differences. So Erzofri eliminates the need for a second initiation dose on day 8. That is going to be your biggest difference between the two. That eliminating of the second dose may improve compliance and convenience, reducing the risk of missed doses during initiation. Because if you're having to do 2 separate appointments, I know we have day 1 and day 8 on Invega. There's some flexibility on that. You can do like a day 1, day 4. There is some flexibility on when that second dose is, but the take home is you're going to have to get that patient in the office twice, right? So if you've got a patient who it's a challenge to get them in the office once, and you want to make sure that you've got that full dose on board because you're not sure if you can guarantee them being there for the second dose, Erzofri could be a really good choice for a patient like that. They do have similar side effects, including those injection site reactions I mentioned, sedation, dizziness, akathisia, EPS as well. Erzofri does offer the strength up to 351 milligrams, which is going to be your initiation dose. And then the Invega, of course, maxes out at 234. Neither product is recommended for moderate or severe renal impairment. You're going to see that on both of them. The max dose of Erzofri is typically 156 milligrams monthly, whereas Invega has a slightly different initiation protocol. So a key message here I want to make sure we get across. Erzofri and Invega Sustenna both deliver paliperidone and share the same overall therapeutic intent for long-acting in management of schizophrenia and schizoaffective disorder. There is no statement, there is no study showing superiority of one product over another. They are going to be, they're going to be using the same monthly maintenance dosage range of that 39 milligrams to 234 milligrams, which underscores that their ongoing therapeutic exposure is essentially equivalent between the two. Efficacy, safety, bioequivalence between the two are comparable, which confirms that switching or selecting between them doesn't meaningfully alter any of your clinical expectations. There's not one that is going to be quote unquote more effective than another. Your main difference is going to be that initiation, and then the other is going to be the dosing intervals that we'll get to in just a moment. So where the two products differ is in the initiation strategy. Erzofri uses that single day 1 350 milligram dose that you see there, while Invega Sustenna requires 2 dose loading regimen on a day 1 and a day 8. So you're going to get a day 1 injection of 234 milligrams. You're going to wait roughly 7 days, and then on day 8, you're going to do a 156 milligram dose. And then after that, you'll follow up with the monthly dosing thereafter. The distinction isn't about clinical effect in this case. It's strictly operational, but it does have important implications for your clinics and your patient flow, especially for patients who are, not counted upon to get to their early appointments, especially, and you want to make sure that we're getting these medications correctly on board. Erzofri is going to allow for that faster elimination because you eliminate the day 8 loading dose. You'll have fewer early phase scheduling hurdles. You'll have a greater likelihood of completing that startup dosing because you're not counting on that patient coming back for that second initiation dose. So for populations where follow-through is really uncertain, such as your patients with unstable housing, transportation barriers, low engagement, recent hospitalization, that single dose start can reduce missed dose risk during the transition, which does make Erzofri a strong choice when the clinical priority is to start and stabilize the patient right out of the gate with the least friction. Functionally, these two LAIs perform exactly the same. The real differentiator here is going to be your workflow. Erzofri simplifies the initiation part, while making it particularly valuable in settings where rapid stabilization and reduced treatment burden are essential. So talking a little bit about Invega, I know I've alluded to it a little bit. So there are 3 different formulations of your Invega LAIs currently. You have the monthly Sustenna, you have the quarterly Trenza, and then you have a 6-month version called Half-Yera. To transition from Sustenna to Trenza, so to go from the 1-month to the 3-month version, patients have to be adequately treated with Sustenna for at least 4 months, with the last 2 doses, the most recent 2 doses, being the same strength. To transition from Sustenna or Trenza to Half-Yera, the patient must be treated with Sustenna for at least 4 months, with the last 2 doses being 156 milligrams or 234 milligrams, or Trenza for at least 1 3-month injection cycle at a dose of 546 milligram or 819 milligrams. As previously discussed, Erzofri and Invega Sustenna are highly comparable long-acting injectable medications, sharing the same maintenance dosing range, bioequivalence, comparable safety, and similar renal limitations. Because their clinical effect is essentially the same, the choice between them is driven more by logistics, workflow, and patient engagement patterns than by a difference in efficacy. And that's very important that everybody understands. Erzofri uses a simplified single dose day one initiation, that 351 milligram dose we talked about, which eliminates the need for the day 8 loading dose required with Invega Sustenna. It makes Erzofri especially appropriate for patients where rapid initiation is critical and follow-up within the first week is uncertain. So then you start to kind of develop these profiles for patients who may benefit for one versus the other, just talking about the logistics. So your ideal patient profile for Erzofri are patients that are at high risk of missing an early follow-up appointment, individuals with poor engagement, such as those with transportation barriers, unstable living situations, inconsistent clinic attendance, things like that. Recently hospitalized patients who need quick transition to an LAI prior to discharge. This may be a good option for them. Settings where a one visit start improves the likelihood the patient actually receives the first dose. Erzofri is optimized for situations where the goal is to start treatment promptly and achieve stabilization with minimal early phase complexity. Invega Sustenna does use that 2-dose loading strategy on day 1 and day 8, which is more suitable for patients who can more reliably attend their scheduled visits. So as we look at the ideal patient profile for an Invega Sustenna, patients who are already stable on a long-acting regimen, individuals who maintain regular appointment adherence, scenarios where clinic workflows more easily support that day 1, day 8 initiation pattern, long-term maintenance patients with established therapeutic response and follow-through. Invega Sustenna does remain a very strong option for stable and adherent patients who are well suited to a traditional 2-step administration and ongoing maintenance structure. And because Erzofri and Invega both provide essentially the same long-term clinical outcomes, your logistics do become the deciding factor here. So you would want to choose Erzofri in a case where you need to get patients started and stabilized really quickly with those fewer number of office visits to make sure that we're getting the full dose on board. And then choosing Invega Sustenna for patients who are a little more stable and engaged in long-term care. And then you have the ability on the Invega product to transition them to the longer interval down the road. So comparing the 2-dose Invega Sustenna to the single-dose Erzofri, Erzofri does offer that 351 milligram dose, which is unique to this formulation. Erzofri is initiated with one 351 milligram IM injection on day 1, offering a streamlined single-visit start. In contrast, Invega Sustenna requires a 2-dose loading regimen, that 234 milligrams on day 1, followed by 156 on day 8. The single 351 milligram dose of Erzofri is designed to achieve therapeutic levels comparable to the combined effect of the 2 shots you would get from Invega, supported by the table's indication that initiation protocols differ, but outcomes and bioequivalence are comparable. Despite the difference in the number of injections, looking at the chart here, both products are listed as bioequivalent, reinforcing that clinical exposure and therapeutic effect are aligned. Because one Erzofri dose replaces the 2-visit Sustenna loading sequence, clinics can reduce early phase drop-off and improve the likelihood that patients fully complete initiation. In short, 1 dose of Erzofri provides what 2 injections of Invega Sustenna aims to achieve: a fast, effective entry into paliperidone therapy with fewer steps and a reduced scheduling burden because you're only having to do 1 appointment instead of 2. So shifting gears a little bit, we wanted to highlight a key workflow item that we've noticed in our pharmacies to ensure that you get the correct dispensed product when you're sending a prescription to the pharmacy. It's important to understand how to properly select Erzofri when that's the product you want to use, when it's desired for patients, to ensure that pharmacies are dispensing correctly. So when you go into your EMR, I know we use a variety of platforms and you're able to search out by brand name and generic, and many of us are in the habit, myself included, of searching by that generic name, right? But when you have more than one product linked to a generic, if you select the generic, depending on which one you select, it may be only linked to one product, and it may not be the product that you intended to do. So when you go into the EMR to initiate the prescription, and you get connected to SureScripts, you need to search for the actual product by brand name. So if you wanted to use Erzofri, you would search for Erzofri by name. If you wanted to use Invega, you would search for Invega by name. Otherwise, if you were to search by paliperidone, for example, and you select that, the pharmacy would get it, and the pharmacy would either have to make the decision on which product is dispensed, or if there's a product link, the software may automatically assign the product, and it may not be the product that you intended. So really important to search by that brand name. If the dose selected exists for both products, the pharmacy, may be likely to select the wrong product if it gives them the option. And I know that Erzofri being the new kid on the block, they may automatically assume Invega when that may not be the case. So it is important that you search by brand name. Do select the brand name, but select the option that says product selection permitted. That way, they are able to, get it through the insurance appropriately. If a pharmacy sees a dose that doesn't align with Invega, they may call for verification. And in doing so, this would delay the onboarding of the patient onto the medication. So, it's just searching by generic names can create all of these complications because, you and I deal in generics, but especially branded products, when they don't have generics. At the time of this recording, neither Erzofri nor Invega have a long-acting injectable generic. But when you search by the generic name and there's more than one branded product linked to it, it can create this confusion. So take home on this, definitely search by your brand name to make sure that you get the product that you intend. So we do have some patient support programs here I wanted to call out, everything from the copay card program to the Erzofri Assist program, as well as some national resources. NAMI is a very good one, the National Council, as well as some of the others you see there. Please feel free to utilize these yourselves, as well as share with your patients as you see it to be appropriate. And that's it for the presentation today. I know we kind of went through that rather quickly, but as I said, we've had a lot of requests from the field, both internally from our pharmacies as well as externally with our clinic partners wanting to learn more about Erzofri and its place in our therapy selections. Because like I said, we do have paliperidone products already out there and we wanted to know what the benefits were. So I want to thank you for spending time with us today on this. And if you have any questions after seeing this, you can always reach out to me. Again, my name is Blake Shoemaker with Genoa Healthcare. I do have my email listed there at cshoemaker@genoahealthcare.com. However, if you have larger questions about exactly what you're able to do with long-acting injectables in your state, maybe you're looking for a pharmacy partner to help you source these medications. If you're a medical practice, you can always reach out to our Genoa Clinical Services team. And that email address is listed there as well. If you have questions, clinicalservices@genoahealthcare.com. I want to thank everybody for spending the time here with us today. If you have any questions, feel free to reach out. But other than that, definitely do your homework on this and, help us take care of our patients by removing that non-adherence from the table when it comes to treating our patients. Thank you.